Chairman. Actually, I have to thank my dear colleague, Professor Magdi Abdelhamid, for putting this program together. And you remember, ya Magdi, that this was our project more than 3 years ago, starting with Professor Pinto, and then Bax, and then finally Barbara Cassidy agreed to put this standalone meeting. So I thank you very much for putting this project in reality. And thank you, Ashraf Badawi, Iris, for this elegant setting. I think this is really wonderful to have this standalone meeting in conjoint with the European Society of Cardiology in Cairo. Actually, I have chosen my favorite 20 late-breaking clinical trials because there was a lot of late-breaking clinical trials in the last ESC in Paris. So maybe some other person will choose another trial or so, but believe me, these trials will shape the future guidelines because they are very important. Okay, let's start with the first two trials in the field of atrial fibrillation. The first one is the INTRUST trial in AF patients performing or doing PCI, so what we call triple therapy. And in this randomized trial, they tried to compare the old regimen, which is the triple therapy, the vitamin K antagonists and the P2Y12 inhibitor and aspirin, three drugs, three antithrombotic drugs, with the new regimen, which is the edoxaban 60 milligram per day, plus just the P2Y12 inhibitor without aspirin from day one. This is the new regimen that they are trying to test. And as you can see for the result, that of course the bleeding was less. This was non-inferior according to the p-value, not about superiority, but it was non-inferior to the triple therapy. And for preventing cardiovascular events, again, you can see that it was non-inferior, except in the first 14 days, as you can see here, that the dual therapy showed more events, more cardiovascular events. That's why you should choose your proper patient. And if your patient is having a high risk of cardiovascular events, then this might be a problem in the first 2 weeks. But after this, you can see that the conservative dual therapy is non-inferior to the triple therapy. And so the conclusion of this trial was that edoxaban and P2Y12 inhibitor with omitting the aspirin are non-inferior to triple antithrombotic therapy in patients with AF and PCI. This was the first trial. The second trial, again in the field of atrial fibrillation, was the AFIRE trial, but in this time was for stable patients, patients with stable coronary artery disease and AF. And the usual therapy is to keep the patient on both oral anticoagulant and aspirin, or a single antiplatelet therapy, whether aspirin or clopidogrel. This was the traditional therapy. But in this randomized trial, they will omit the antiplatelet therapy and keep the patient only on rivaroxaban, although he is having coronary artery disease, stable coronary artery disease. And let's see what was the result. Regarding the efficacy, preventing cardiovascular events, it was again non-inferior. The single therapy the monotherapy was non-inferior to the combination therapy. And as regard the bleeding, definitely it was much better than the combination therapy. So the conclusion of the AFIRE trial again was that omitting aspirin and keeping rivaroxaban alone was better than its combination with an antiplatelet in chronic coronary syndrome patients with atrial fibrillation. Now we shift to 3 more trials regarding the antiplatelets, not the anticoagulants now, the antiplatelets in acute coronary syndrome patients. The first one was the ISAR-REACT trial, which compared ticagrelor with prasugrel, head-to-head comparison for the first time to see which one of these strong antiplatelets is better in patients with acute coronary syndrome. And the result was in favor of prasugrel. Prasugrel was better in preventing cardiovascular events. This was the outputs, and the p-value was significant. Regarding the bleeding, again, there was no difference. All of you might be thinking that prasugrel was showing increased bleeding. No, there was no difference in bleeding. So the conclusion of this trial was that prasugrel bests ticagrelor in acute coronary syndrome patients. The next trial, again regarding antiplatelets, was the THEMIS trial that studied the effect of adding ticagrelor on top of aspirin in patients with stable coronary artery disease and diabetes. The standard therapy is to keep the patients on aspirin only, but in this study they thought of adding ticagrelor on top of aspirin, and the result for diabetic patients was a borderline beneficial effect of ticagrelor, but the bleeding rate was very high. As you can see, there was increase in bleeding when adding ticagrelor on top of aspirin. But in the subgroup of patients with history of PCI, this was of benefit. Ticagrelor fared much better than keeping the patient on aspirin only, and compared to patients with no history of PCI, where there was no any benefit of adding ticagrelor on top of aspirin. So the conclusion of the THEMIS trial was that ticagrelor, when added to aspirin, did not benefit diabetics with chronic coronary syndrome, except those with the prior PCI. They started first the dose of 90 milligram BID, but then they shifted to the 60 milligram BID. The third antiplatelet trial was the popular genetics, and this again is the comeback of the clopidogrel. The investigators tried to put clopidogrel after doing genetic testing to see if the patient is suitable with the cytochrome P activity. If the patient is suitable after genetic testing, then he would be randomized against the prasugrel or ticagrelor. And again, the study was in favor of clopidogrel after doing genetic testing regarding the primary endpoints and the major bleeding. This is the primary outcome. And so the conclusion was that this trial, the genotype-guided strategy with clopidogrel, was non-inferior to ticagrelor or prasugrel after primary PCI. Two more trials in the field of ACS, but this time I'm choosing trials studying the high sensitivity troponin. The first one was the rapid TNT, and it showed that a high sensitivity troponin with an 1 hour exclusion test proved to be as effective as the traditional 3 hours regimen. So again, this was a reassuring regimen that the 1 hour troponin T protocol was supported with this trial. The second trial is the historic trial, and again it proved the same conclusion, that a high sensitivity protocol with a single cardiac troponin measurement by high sensitivity troponin I assay can safely and effectively rule out myocardial infarction at presentation just after 1 hour. 4 more trials in the field of STEMI. Again, you remember the oldie but goldie DYNAMI trial, and in this time they presented the 16 years follow-up. Imagine that they are presenting the 16 years follow-up, and still primary PCI was better than fibrinolysis even after 16 years. So a very reassuring trial. Even cardiac death was better with primary PCI after 16 years compared to fibrinolysis. So the DYNAMI 2 trial proved that primary PCI was still better than thrombolysis in STEMI even after 16 years. The next trial is the famous COMPLETE trial, again in the field of primary PCI, but this one was the contemporary primary PCI trial, and it was testing the complete versus the culprit-only strategy. And as you all know, that the complete strategy was much better after 5 years of follow-up, and even the composite endpoint of cardiovascular death, new MI or ischemia-driven revascularization, was much better than the culprit-only strategy. So STEMI patients did better with complete culprit and non-culprit revascularization. And still in the STEMI field, there were 2 trials that proved to be not effective in the contemporary management of primary PCI. The first one is the New Zealand oxygen therapy acute coronary syndrome, and it proved that oxygen, routine oxygen was not helpful in our contemporary PCI management. Routine oxygen did not benefit acute coronary syndrome patients without hypoxemia. The patient should be hypoxemic in order to benefit from oxygen. The following one is again a negative trial that proved that remote ischemic conditioning was not different from not using it. So again, it proved that remote ischemic conditioning prior to contemporary primary PCI did not improve clinical outcomes in STEMI patients. 4 trials in the field of heart failure. The first one is the Galactic trial in the setting of acute heart failure, and it proved that using intensive vasodilators like nitrates, hydralazine, ACE inhibitors, ARBs, or sacubitril valsartan proved to be of no benefit to patients with acute heart failure. So again, this was a negative trial, and the conclusion was that early, intensive, and sustained vasodilators in acute heart failure did not improve outcome. The next trial was the Paragon heart failure trial that tried to use the sacubitril valsartan trial in patients with HFpEF, heart failure with preserved ejection fraction. And as you can see, that the p-value was borderline, no benefit, but there were 2 subtypes of patients that proved to be to get benefit. The first one was the females. We don't know why. They got benefit from the Entresto in HFpEF, and the other one subgroup of patients were those patients with ejection fraction below 57%. They got benefit. So as you can see, that these 2 groups deserves further investigations, but the final word from the Paragon heart failure was that sacubitril valsartan showed no significant benefit in patients with HFpEF. The third anti-heart failure trial was the MITRA trial, and as you remember, that compared to the COAP trial, it showed negative results after 1 year of follow-up. And there was a debate why both mitral clipping in 2 trials showed contradictory results. But what we knew from this trial, that after 2 years of follow-up, still the MITRA trial was negative. There was no benefit of mitral clipping in patients with mitral regurg and heart failure. So the final word was that mitral clip still not better than medical therapy after 2 years in the mitral follow-up. The famous heart failure trial in the last ESC was the dapagliflozin in patients with heart failure with reduced ejection fraction by the famous John McMurray. Again, he was very lucky in this study, and he chose the right agent, and dapagliflozin, which is in Egypt Forxiga, proved to be benefit in patients with heart failure, with chronic heart failure, and the p-value was many zeros. So very significant dapagliflozin as an anti-failure treatment versus placebo. And these outcomes was worsening heart failure event, and cardiovascular death again was significant with dapagliflozin. And the strange thing about this is that whether the patient is diabetic or not did benefit from this drug in acute heart failure, in chronic heart failure patients. So dapagliflozin provided significant benefits among patients with HFrEF, even in those without diabetes. 2 further trials in the field of ICD. The first one was from the Swedish registry, and it was studying ICDs for primary prevention in patients with heart failure, and it showed good benefit after 5 years of follow-up. Significant difference between ICD-treated patients versus matched control. This was the Swedish registry, and the final word from this trial was that among the HFrEF patients, ICD was associated with lower mortality when used for primary prevention. The second trial in the field of ICD was the DAPA trial, using ICD after primary PCI, and in this term it was a follow-up of 10 years of follow-up, and it showed that all-cause mortality was reduced with the ICD, a significant p-value compared to the control group, and even in patients with ejection fraction above 30%, they got benefit with the ICD. So again, the final conclusion from this DAPA trial was that early ICD reduced mortality after primary PCI. The last 3 trials I would like to present was in the field of prevention, and these are were very important trials. The first one was salt substitution in Peru, in Lima, Peru. That investigators provided people in 5 rural and semi-rural communities with salt 25% replaced with potassium, 75% sodium, and 25% potassium. And they gave this salt to the people at home and to the people doing food, shops for foods. And in the follow-up of this patient, of this community, they proved that replacing this salt showed a reduction in the incidence of developing hypertension, and the hazard ratio was 0.45%. So 55% reduction in the incidence of hypertension. Hypertension was defined as a blood pressure above 140 over 90. So replacing high sodium salt at the community level lowers blood pressure and halves the incidence of new hypertension. The next trial was, again, a very important trial that showed that combined effect of lower LDL and lower systolic blood pressure proved to be of benefit in preventing cardiovascular disease. And this was a genetic investigation from the UK Genome Bank, and they followed 450,000 patients, and they proved that patients with genetic lower blood pressure and genetic lower LDA combined together, and mind you, the very mild difference in blood pressure, the systolic blood pressure was lower by 3.1 millimeter mercury, and the LDL was lower by 13.9 milligram per deciliter. And you can see here that the combining both genetic variants proved to be very effective in lowering the cardiovascular events. It proves the concept of lowering the systolic blood pressure even minor with the LDL. So the final word from this trial was that genetic variants with lifetime exposure to combined lower LDL and lower systolic blood pressure have independent, additive, and dose-dependent effects on the lifetime risk of cardiovascular disease. The last trial I chose to end with is the future of preventive cardiology. This is the Orion 11 trial that tested the efficacy of inclisiran, which is a 6-monthly injection, and it proved that after 18 months, it have a sustained lowering of LDL by 50%. And I think that this drug, with this 6 months, every 6-month injection, it's not a vaccine, but it's like a vaccine-like preventing the cardiovascular events. We are still waiting for the cardiovascular outcome of this futuristic LDL lowering drug. And thank you very much for your attention. Inclisiran twice yearly injection had 50% LDL reduction. Thank you very much.
Thank you very much, Dr. Sameh. Fantastic lecture.